Hello and welcome to the second part of this lecture series, which will really be focused in on observation and historical questions or questions we should ask a patient who has a suspected hip pathology. I know this is somewhat out of order because typically we start with history, but with the hip, if you recall in the first lecture, one of the things that I said is your observation is going to be key, right? Because if a patient has a hip pathology, it's going to be apparent in their gait pattern, right? So we're going to start with observation first because it's one of the most important assessment techniques that you'll use in the evaluation of a hip pathology. When we think about the hip, one of the first things that we start with is inspection. Of course, we can certainly still ask our history questions first. I'm not saying that. But what I've said in previous lectures is that our evaluation of the patient begins when, you guys? Right. It begins as soon as that patient walks into that clinic or as soon as that patient walks off the field or court, right? We're starting our assessment. They don't know we're starting our assessment, but we're certainly starting our assessment with our inspection or our observation of the patient, right? Within the hip in particular, one of the things that we do to determine return to play relatively quick is functional assessment. So, but of course, there's a caveat there. The caveat is, can that patient bear weight? Is that patient functional? And if they aren't, or if they can't, then we skip that step and we start our observation. Now, observation of the hip is certainly going to involve assessment of gait, but even more specifically, there are specific patterns, abnormalities that we are looking for with the hip in particular, and those are listed here. So there are these hip angulations that tell us a lot about a patient's the bony architecture of the coxofemoral joint. And so those are here, they're listed here, and we can see them. We have the angle of inclination, which includes coxa vara and coxa valga. And we have the angle of torsion, which will include anteroverted and retroverted hips. And we're going to talk about these in different slides, so you don't need to know them right this second. But you certainly should know that the coxa vara and valga fall into the angle of inclination, and that the anteroverted and retroverted fall into the angle of torsion categories because they are completely different in terms of what happens to the femoral head. So our first stop is going to be right here where we're looking at this slide and we're seeing a femur from the top down, right? So we're standing over a full femur and we're looking at it, right? So take that stance and then understand this slide. So anteroversion, normally what we would say is that the hip is normally anteroverted. Most often the normative value for anteroversion at the hip is about 8 to 15 degrees. And so we can see that we have some degree of anteroversion, but what happens when we fall outside of that normative value? That's what we're going to talk about right now. When we fall outside of that 8 or 15 degrees, and essentially we get two different extremes in terms of angles of torsion. The first extreme that we get is anteroversion, so an angle that's less than 8 degrees. And the second extreme that we get is retroversion, an angle that's greater than 15 degrees. So we have extremes, right? When we look at these images here, we're going to look at image 1 and image 2 first. What we can see happening at the femoral head is extremely important to understand in terms of the concept. When we think about angle of torsion pathologies or deformities, we have to think about the femoral head moving in the transverse plane. So it's either rotating anteriorly or rotating posteriorly in that transverse plane of motion, right? So let's take a look at this. This is an anteroverted hip. We can see that that femoral head is rotated anteriorly, right? And so as a result, because that rotation makes the angle less than 8 degrees, this is considered a pathologically anteroverted hip. What we'll see happening in patients who have that decline in the angle of the femoral head is they will toe in. They will have a toe in pattern to substitute, right? On the opposite end of that spectrum, we said retroversion was an angle that is greater than 14 degrees, right? And so when we look at this image, we can see that what's happening to that head, it's rotating posteriorly, right? And as a result, can you see how the angle has increased, right? So this angle increases, and as a result, that patient substitutes by toeing out. So you have an anteverted patient who has less of an angle, the head is rotated anteriorly, and so you get a toe-in position. You have a retroverted patient whose angle is greater than 15, right? Whose head has rotated posteriorly and has started to tors or turn. And so they toe out to compensate, right? And let's take a look at this image here, because I kind of like it. Because again, what it tells me is that everybody, every human has some degree of anteversion, right? Between 8 to 15 degrees, like I said, is very normative in nature. It's when we fall outside of those, right? So when we fall outside of 8 degrees and we're less than 8 degrees, then we have that anteverted hip posture with the foot toeing in. Or if we fall outside of that 15 degrees and the angle is larger, then we have that retroverted foot posture and that patient is toeing out. This becomes important if you're not tracking, because as we observe our patient walking into our clinic, one of the things are they toeing in? Are they toeing out? That would tell you at least, okay, something's probably going on at the femoral head, right? Either they're anteverted or they're retroverted. So again, this is something that we should pick up in our observations. So what compensations can we expect when a patient has an anteverted hip, right? Because that's important. Or what compensations can we expect if a patient has a retroverted hip or femoral head, right? So if the patient is anteverted, we already said they're going to have toeing in, right? They're going to suffer from a toe-in posture. But we also know that these patients have increased subtalar pronation. They suffer a lot from lateral patellar subluxations, and they're going to have lots of torsion at the tibial femoral joint, particularly medial torsion. So a lot of medial wear and tear on that medial condyle of the tibia. The opposite applies for retroversion, right? So they're going to toe out, most often be in a subtalar supinated position, and then last but not least, they're going to have lateral wear and tear on that lateral condyle. So I challenge you to kind of just try those foot postures and see what happens to the condyle and how much pressure is on each side of the condyle as you assess these different abnormalities or angles of torsion. So one of the things that we can do in the field is actually to assess the amount of anteversion, not retroversion, only anteversion, is we can utilize the Craig's test. And I'm going to show you that in the laboratory setting when I see you next week. So we'll talk about Craig's test when we get there, but the Craig's test is the test, the gold standard test to use in the clinical setting to assess whether or not a patient has an extreme anteverted position. But again, there are other things with our eyes that will tell us if they're anteverted, right? The toe-in foot position, the toe-in foot position. If they're retroverted, the toe-out foot position, right? So these are all things that we want to start adding to our clinical toolbox to allow us to figure out if these patients have any angle of torsion issues. Okay. The other type of angulation dysfunction that we most often see is going to be an angle of inclination issue. So in the angle of torsion pathologies or dysfunctions, what we said is that the head rotates in the transverse plane, right? So we get a rotation that's happening, which increases or decreases the angle. With our angle of inclination pathologies, which are Coxa Vara and Coxa valga, the angle of inclination happens by the head moving in the frontal plane, right? So think adduction, abduction. So essentially what we see is normatively, our angle of inclination would be 130 degrees in the frontal plane. So what happens when that head moves up or shifts down? What we see is in a Coxa Vara position, right? The humeral head shifts inferiorly and shortens the angle or makes the angle smaller, and so then we get what's called a Coxa Vara. Or we could have an increase in that angle, right, where the head shifts superiorly. And I want to be very clear here. It's not just the head moving, right? The neck is attached to the head, which means the neck is also getting stretched or elongated, right? And so that's what creates this angle here. And so we have an increase in that angle, and that's called Coxa valga. A decrease in that angle would be Coxa vara. A increase in that angle would be Coxa valga. And normative would be around 130 degrees. So as we progress, the compensations that you could expect with a Coxa vara versus a Coxa valga they're all right here. What I will say, the key to me is this related posture here. So if a patient has a Coxa vara, so a shortened, smaller angle, right, in the frontal plane, then we can expect that they're also going to have genu valgum at the knee, right? So they're going to be knock-kneed. Hope that makes sense. If a patient has a Coxa valga, then we can expect at the knee they're probably going to have a genu varum, right? So opposite, if we have Coxa valga at the knee, we have genu. If we have Coxa valga at the hip, we have genu varum at the knee. We have Coxa vara at the hip, then we have genu valgum at the knee. So they're kind of opposites. Whatever is happening at the hip is the opposite happening at the knee, right, you guys? Okay, I did a really good job of teaching that, didn't I? Okay, so observational test for Coxa vara. Remember, that's the angle that's going to get smaller over time. Normative is 130. So anything less than that, but in particular, anything that approaches 110 degrees is considered Coxa vara. Remember, at the knee, we can expect a genu valgus deformity at the knee. But we can do a few different tests. Again, we'll do these in lab, so I'm not going to spend a whole bunch of time in a lecture talking about them. But Nilton's line, where we look at the angle between the anterior superior iliac spine and the ischial tuberosity. And that's going to tell us the relation of the greater trochanter. And so we'll talk about that in lab. The other that we can do kind of eyeball is Bryan's triangle. I'm going to argue that you'll need an x-ray to do this one, but it is certainly something that your textbook alludes to and mentions, so I'm putting it here for exam purposes. So here's a clinical example and why I think it's important that you understand the angles of inclination, right? In this particular case, what we are looking at is a Coxa vara, right? An angle that's less than 130, a Coxa vara deformity, right? Where that femoral head has kind of shifted down. And so then what we see, compensatory motions at the knee are going to be genu valgum, and then we can obviously see excessive pronation at the foot, right, you guys? So we can see how something at the hip will certainly impact the knee and the foot. So it isn't far-fetched that even though we have a hip pathology, that we would need to assess what? The knee and the ankle joint and the foot joint, because it's going to impact the distal joints, right? So just something to keep in your clinical toolbox as you progress. One other thing that we have to consider as clinicians are leg length discrepancies. We really hadn't talked about them a lot. Sometimes we get to them in the knee, but here's where we really want to focus in on any leg length discrepancies that our patient may have, right? So you can kind of see we're looking at dysfunctions that can occur with our patient when they have a hip pathology, or dysfunctions that could certainly lead to leg length discrepancy. So you can look at it either way. A patient can be born with a leg length discrepancy, or something functionally can cause a leg length discrepancy in our patients. And so essentially what we're going to do is assess for two different types of leg length discrepancies. We're going to assess for a structural leg length discrepancy, and then we're going to assess for a functional leg length discrepancy. And the way that we do that is using a measuring tape. But in lab, what you're going to learn is there's a difference between structural and functional measurements. And if anybody wants extra credit for that, you can email me the answer between what is the difference in measurement between a structural leg length and a functional leg length. A structural leg length discrepancy is caused by a patient being born with a smaller bone, right? So, or shorter bone. So examples would be a shorter femur, a shorter tibia, right? A functional leg length discrepancy is caused by an imbalance of the muscular system. So examples would be tight hip flexors, right? Tight hamstrings could potentially cause a leg length discrepancy. An IT band can cause a leg length discrepancy. Those would be functional things, right? Those are things that we as clinicians can certainly impact and improve. Our structural discrepancies certainly can be corrected through the use of orthotic intervention, but we can't do any massage to make that better or any stretching to make that better. So for extra credit, 5 points extra credit, the first person to email me and tell me how you would measure differently to rule out a structural versus a functional leg length discrepancy. So there are many ways to kind of assess for structural discrepancies. In other words, if you want to determine which bone is shorter or longer, you can certainly do that. And so I give you tips to do this, but in the clinical setting, we really don't do it very often, you guys, right? So this is more textbook versus clinical application, but still important for the exam, probably. So if you go from the greater trochanter to the lateral joint line, then you'll assess the length of the femur, right? That makes sense. And then if you go from the medial joint line to the medial malleolus, you'd be assessing the length of the tibia. So these are different ways to determine how long the tibia is, how long the femur is, and these would be good assessments to help you determine which bone is the causative bone or the bone that's causing problems, right? So these are structural ways to assess individual bones, right, you guys? Okay, so as we progress, other ways to look at leg length discrepancies is to have the patient lie in a supine position, and as you can tell, kind of get into that Godfrey 90-90 position, but really what you're looking at is alignment here. So you're looking at alignment of the patella, alignment of the tibial tuberosity. These are more clinically functional because you can just look really quick. You can also have the patient lie in a prone position and pull their legs or their knees into 90 degrees and then look at calcaneal height, if that makes sense. So that's what this picture is representing here. So there are clinical ways to do that and to get around using a measuring tape in the clinical setting. So in terms of leg length discrepancies, hopefully you've emailed me by now to get your 5 points, but let's go ahead and talk about the difference between structural and functional leg length discrepancy. So for a functional leg length discrepancy, you're going to start in the center of the umbilicus, which makes sense, and you're going to travel all the way down to the medial malleolus, and you're going to measure this in centimeters most often. So again, for a functional leg length discrepancy, we're going to start in the umbilicus and we're going to go all the way down to the center of the medial malleolus. This would be for a functional leg length discrepancy, right? Okay, so my question to you is, what would you do for a structural leg length discrepancy? Now we're moving into ranges of motion, because the reality is in an eval, we're going to have our patients move through ranges of motion. At least I hope we do. And so knowing the normative values and knowing how to measure those with the goniometer, I think is clinically important, particularly in the hip. So I've listed the most current expected normative values for all of the motions that occur at the hip. So with hip flexion, we're expecting about 110 to 120 degrees of hip flexion. For hip extension, of course, it's always going to be less, so about 10 to 20 degrees of hip extension, but there are exceptions to every rule, right? We will have someone who have 40 degrees of hip extension, I'm sure, in lab, right? So it just really depends on the patient. Our best assessment is going to be what? Side-to-side comparisons. For hip abduction, we're expecting about 30 to 50 degrees. Hip adduction gets a little tricky, but about 30 degrees. In internal rotation, for external rotation, we're expecting about 40 to 60 degrees of motion. And then for our internal rotation, we're expecting about 30 to 40 degrees. So these are all normative values that you really should know. When you're assessing a patient and you have them flex their hip, where are you expecting them to be in terms of ranges of motion? Well, 90 degrees just doesn't get it, right? And some of you will have 90 degrees of hip flexion and we will laugh at you in lab. It will be okay. All right. Okay. So now we get to history. We've talked about observation. We've gone through all of the key components of observation, right? Observation is huge. We have to look at the different angles of inclination, right? We've got the actual angle of inclination, which is going to be Coxa, Vara, and valga. We have the angle of torsion, which is going to be anteversion and retroversion. Additionally, we have to think about leg length discrepancies and whether or not those are the culprits. And with leg length discrepancies, we have two different types. We have structural and functional. Send me an email for the extra credit if you want it. Now we progress into the history component. And so history questions specific to the actual hip itself. I've tried my best as we progress through each joint to give you specific history questions for each joint. So with the hip, the age is probably one of the most important historical questions. Why? Because we know that older patients who fracture their hips, they have less of a lifespan left, right? So this is a predictor. So we want to ask age, number one, because bones are typically brittle as we progress and get older. So patient age is absolutely important. We know that older patients are more susceptible to hip fractures, and so that just becomes an important question to ask. We want to ask about trauma, and what we're worried about is what? The femoral triangle, right? We're worried about, did they take an anterior blow to that femoral triangle? Is this a medical emergency? Are we tracking there, guys? Similarly, the type of pain. Is it burning? Is it tingling? Again, we're thinking femoral triangle when we're asking this historical question. And then the last four are very common, right? So is the condition getting better? What exacerbates it? What movements aggravate it? And then common activities that will irritate it as well. The top three questions are questions that we really need to be asking our patients. And question number one, you might already know, right? Because you might have it in their patient file, so you may not need to ask it. But a huge red flag for older patients, those going into PA, those going into PT school, is their age at the time that they slip and fall and maybe fracture their hip, okay? All right, so we have diagnostic clues and things that kind of help us become detectives as we assess the actual hip joint. If a patient's complaining of, I'm going to show you how to use this chart. If a patient's complaining of deep, dull aching within the hip, most likely that's arthritis. Makes sense? Okay. If they have sharp, intense, sudden pain, and that pain is associated with weight bearing, then most often we're thinking a fracture of the hip. Are we tracking, guys? So differential diagnosis right here, right, guys? Okay, I'm excited. Hopefully you are too. You can actually see my excitement today. Okay, so then tingling that radiates. Well, we're thinking some type of radiculopathy, some type of neural injury, right? But then, okay, let's go to something that's a little bit maybe not intuitive to us, but certainly something that I've seen in young student athletes that I'd never seen in clinical practice before. So unremittent, long duration pain. We're thinking arthritis, but we're also thinking that we need to rule out cancer, right? So all of these possible causes of the hip, we have more. We're getting ready to transition into our pathology lecture online. So I'm extremely excited. I hope you learned, at least, if nothing else, the different angles at which we need to observe or dysfunctions that can occur to the femoral head. You can assess that when it's walking into your clinic. I hope you learned a few historical questions that you would ask a hip patient, maybe that you wouldn't ask a knee patient or a foot and ankle patient. Looking forward to the pathologies lecture.